Each pulse of fluid reveals the critical pressure within.
Welcome to Essentials of Critical Care. Today we gonna discuss another very important topic. We have tried to make it easy for you. Intracranial pressure (ICP) monitoring. Introduction. Intracranial pressure (ICP) is the pressure exerted by contents within the skull, which include brain tissue approximately 80%, blood approximately 10%, cerebrospinal fluid (CSF) approximately 10%. Normal ICP ranges between 5 to 15 m of mercury in adults. Monroe-Kelly doctrine states, skull is a fixed space and increase in one component must be compensated by decrease in another. Failure to expand results in increase ICP with decrease in cerebral perfusion and brain ischemia herniation. Indications for ICP monitoring. Severe traumatic brain injury with GCS equal or less than 8. Abnormal CT scan, hematoma, edema, contusion. Normal CT scan with 2 of the following factors. Age more de 40, SBP less than 90 mm of mercury. Abnormal motor posturing. Other indications. Intracerebral or subarachnoid hemorrhage, hydrocephalus. Hepatic encephalopathy with risk of cerebral edema. CNS infections in selected cases. Post-neurosurgery monitoring. Methods of ICP monitoring. Invasive monitoring, gold standard. 1. Intraventricular catheter, external ventricular drain EVD. Most accurate method, gold standard. Inserted into lateral ventricle. Advantages. It measures ICP. Allows therapeutic CSF drainage. Disadvantages increase infection risk. Technically more demanding. 2. Intraparenchymal monitor, it's fiber optic. Placed in brain tissue. Advantages are it is easy inserted, lower infection risk versus EVD. Disadvantage that it cannot drain CSF and chances of drift in calibration. 3. Subdural, epidural sensors. They are less invasive but less accurate. B. Non-invasive methods, adjuncts. Optic nerve sheath diameter by ultrasound. Transcranial Doppler by measuring pulsality index. Court MRI signs showing midline shift, effacement. Tympanic membrane displacement. Important point is that these do not replace invasive monitoring. Measuring optic nerve sheath diameter (ONSD) is a valuable, bedside, non-invasive method to estimate raised intracranial pressure (ICP). It's commonly done using point-of-care ultrasound (POCUS) in ICU and emergency settings. Principle. The optic nerve sheath is continuous with the intracranial subarachnoid space. When ICP rises, CSF transmits pressure to sheath which expands, and is measurable on ultrasound. Equipment is high-frequency linear probe, 7.5 MHz of ultrasound machine B mode. Patient is placed in supine position with eyes closed, do not apply pressure. Apply copious gel over closed eyelid but avoid excessive probe pressure, can falsely reduce ONSD. Probe placement. Place probe gently over the closed upper eyelid. Orientation. Transverse view, marker toward temporal side. Sagittal view, marker toward head. 2. Identify structures. On ultrasound you'll see globe appears as anechoic, black. Retina appears as hyperechoic line. Optic nerve ASA hypoechoic tubular structure behind globe. 3. Measurement point, most important. Measure 3 mm posterior to the retina. This is the standard point because sheath expansion is most sensitive here. 4. Measurement technique. Measure inner edge to inner edge. Perpendicular to optic nerve axis. Take 3 measurements per eye and average them. Normal versus abnormal values. ONSD. Interpretation. Less than 5 mm. Normal ICP. 5.0-5.7 mm. Borderline. Greater than 5.7-6 mm. Raised ICP likely. Cutoffs may vary slightly depending on population. Key tips for accuracy. Measure both eyes. Take average of multiple readings. ONSD correlates reasonably with invasive ICP monitoring. Now talking about ICP waveforms, very important in ICU. Normal ICP waveform has 3 peaks. Components. P1 is percussion wave. It is due to arterial pulsation. Normally its highest of 3. P2 is tidal wave. It reflects brain compliance. Increase in P2 means decrease in brain compliance, a bad sign. P3 dicrotic wave corresponds with aortic valve closure. Normal pattern. P1 greater than P2 greater than P3. Abnormal pattern. P2 greater than P1 means reduced brain compliance and is an early warning of raised ICP. Pathological ICP waves. Lundberg waveforms. A waves, always abnormal plateau waves. Sudden rise to 50 to 100 m of mercury. Last 5 to 20 minute. Very dangerous means impending herniation. B waves. Rhythmic oscillations 0.5 to 2 per minute extends for less than 5 minutes, appear in unstable ICP. Seen in decreased compliance. Mechanism. Changes in cerebral blood volume. Linked to respiratory patterns and vasomotor instability. Clinical significance. Suggest reduced intracranial compliance. Often precede A waves. Seen in moderate ICP elevation. Sleep can be physiological in mild form. C waves. Normal. Less clinical significance. Small amplitude oscillations. ICP variation less than 20 mm mercury. High frequency. 4 to 8 per minute. Mechanism is related to Traub-Herring-Mayer waves, blood pressure oscillations. Reflect systemic BP and autonomic changes. Associated with cardiac and respiratory cycle. If you see B waves, watch closely. A waves, act immediately. ICP assessment and interpretation. Key parameters. 1. ICP values. Normal, 5 to 15 m of mercury. Treat if more than 20 to 22 m of mercury. 2. Cerebral perfusion pressure, CPP. Formula. Cerebral perfusion pressure equals to mean arterial pressure minus intracerebral pressure. CPP equals MAP. ICP. Target. 60 to 70 m of mercury. Low CPP is associated with cerebral ischemia. 3. Trends are more important than single value. Rising ICP trend means worsening edema, bleed.